So hemodynamic liver diseases. Hemodynamic liver diseases, the questions are going to come from asking you about, is it a hepatic vein thrombosis, a portal vein thrombosis, or a splenic vein thrombosis? And it's usually because it's a thrombosis, you're thinking about any hypercoagulable states that the patient might have in the question setup. So it's typically a patient who has polycythemia vera, a pregnant patient, a person using oral contraceptives, or someone with hepatocellular carcinoma, or any other hypercoagulable state that you can think about. So usually, if it is a hepatic vein thrombosis called Budd-Chiari syndrome, it helps to think about the anatomy of the liver in terms of what's going in. It's going to be a portal vein, a hepatic artery, and a bile duct, and what's coming out of the liver eventually is the hepatic vein. So if the hepatic vein is blocked, everything is going to back up into the liver. So when you look at an ultrasound, they're going to say there is all this collateral vessels that are appearing like a spider vein, like a spider web pattern. Another diagnostic tool is a hepatic venography. So now what about a splenic vein thrombosis? A splenic vein thrombosis, the classic history is going to be someone who's already has some kind of pancreatitis, acute or chronic. And splenic vein thrombosis is basically going to cause stomach varices, specifically in the fundus of the stomach. Because there is also gastroduodenal vein thrombosis as well, which can also cause stomach varices, but that's not as common. So this is the most common one, the splenic vein. Now the portal vein thrombosis is going to cause also gastric varices, but it's also going to cause predominantly esophageal varices. So the differentiating point is the portal vein thrombosis is going to cause esophageal and gastric varices versus splenic vein thrombosis is going to cause gastric varices in the fundus specifically. Now, in general, the treatment for all of them would be you give them thrombolytics, TPAs, and anticoagulate them, and you assess them for the MELD score to see if they need a liver transplant. So MELD score normal value is 6. So anything 15 or more, they need a transplant, because a MELD score is basically predicting a 90-day mortality in these patients. So the MELD score is looking at bilirubin, INR, creatinine, and sodium values, and then that's how it's calculated. Another thing is in terms of the symptoms that they give. Usually for Budd-Chiari syndrome, they present with abdominal pain, jaundice, hepatomegaly, and ascites. So, but the most important thing is how would you differentiate all of this? And that's going to be exactly based on the anatomy of everything backing up. Another one they can ask about is called hepatovenoocclusive disease. Now, this is the terminal hepatic venules that get blocked, and this is often seen in patients with bone marrow transplants. So sometimes you may not know all of the information, but there are just little clues that they're going to drop, whether it's pancreatitis or someone who's taking oral contraceptives, or it's a bone marrow transplant patient. So sometimes those little clues can also help you coming to the right diagnosis. Okay.